Bismillahirrahmanirrahim. Assalamu alaikum and very good morning. I'm Dr. Shaheen Kousar, consultant hematologist, section head hematology at Dow University of Health Sciences. Today I'm moderating the session of red cell disorder, current and future strategies at 24th PSH annual conference. Before moving on to the speaker, I would like to introduce chair and co-chair of this session. Dr. Ghulam Nabi Kakepoto, an eminent hematologist, is chair of this session today. Thank you so much, sir, for accepting this invitation. We are honored to have you here. He is consultant hematologist at Royal Wolverhampton Hospital. His primary interest is thalassemia, especially preventive aspect in countries like Pakistan. Professor Samina Naeem, a prestigious hematologist in Pakistan. Thank you so much, madam, for being here as a co-chair of the session. We are very pleased to have you here. And she is dedicated. She has dedicated her life for the teaching and training of undergraduate and postgraduate hematology students. She is a member of faculty of hematology at CPSP. She is currently working as a consultant hematologist, Hamid Latif Hospital Laboratories. She is former president of Pakistan Society of Haematology and former head of the Department of Pathology at King Edward Medical University. She has 40 publications on her credit. Now let's move on to the speaker. I would like to introduce and invite speakers one by one. And at the end of the session, we will take question and answer in Q&A sessions, including the panelist discussion. And at the end, I will request co-chair and the chair to conclude the session. So my first speaker is Professor David Rees, Professor of Pediatric Sickle Cell Disease at King's College Hospital. Professor Rees is a consultant pediatric hematologist with special interest in sickle cell disease, thalassemia, general pediatric hematology, prenatal diagnosis for hemoglobinopathies and porphyria. His research interests include clinical and molecular characterization of red cell disorders. Professor Rees has 6-year full-time research experience in laboratory, clinical aspect of inherited anemias, and he has written more than 70 research papers in peer-reviewed journals. He is a member of steering group of NHS Sickle Cell Society and also on the editorial board of British Journal of Hematology. He is a peer reviewer of BJH Heme Blood Archives Disease in Blood Childhood, Hematologica, American Journal of Hematology, Journal of Pediatric Hematology and Oncology. Today, Professor Rees will talk about emerging therapies in sickle cell disease. Over to Professor Rees. Thank you.
I'd like to thank the organisers for inviting me to give this talk on emerging therapies in sickle cell disease. I'm David Rees. I'm a paediatric haematologist at King's College Hospital and King's College London in London with an interest in sickle cell disease and inherited red cell disorders. Sickle cell disease is a complicated condition, but it's simple in some ways. This diagram illustrates that everything starts with hemoglobin S polymerization, and then there's a cascade of downstream events which become increasingly complicated. Almost everything that you measure in sickle cell disease is abnormal, and it's often hard to know, or it's still hard to know, what things are actually important in terms of causing disease and what things are merely coincidental sort of epiphenomena which happen beside the important events. And that difficulty has really been one of the things which has influenced how treatments have been developed and what treatments work and which ones don't. This slide, this diffusion contrast microscopy briefly illustrates the process of polymerization filmed directly under a microscope, which is the start of all the sickling problems. You can see the polymers forming and branching under deoxygenated conditions and forming this very complicated network, in a very quick time. And given that this occurs in every red cell in the body, you can see how damaging this might be, given that red cells are basically just bags of hemoglobin. The end result of the polymerization is this blood film, which most people are familiar with, showing pointy, damaging sickle red cells, again, which you can imagine don't circulate well and result in a whole raft of problems. So going on to the general management approaches, which I'll mention not in this order, but there's different ways of dealing with sickle cells. There are stem cell treatments, so in a way the most curative treatments, and stem cell transplants of one sort or another have been around for 30 or 40 years now. Increasingly, there's gene therapy, either gene addition or gene editing. Inhibition of hemoglobin S polymerization is the other direct way of trying to manage sickle cell disease, and it is possible, in theory, to directly inhibit the process I just showed, or you can slow it down by reducing the concentration of sickle in red cells, either by increasing hemoglobin F levels or reducing the amount of hemoglobin in the red cells, or by increasing oxygen affinity of hemoglobin, in that it's only the deoxygenated form which polymerizes. Then the other approach, which has been the one that's been studied most extensively, is to inhibit the downstream complication of polymerization. So not the first process, but the whole cascade of abnormal events, the inflammation, the vaso-occlusion, the abnormal coagulation, all those things can be targeted by separate drugs with a view to trying to improve the condition. And the final group is looking at improved symptom control. At the moment, most management involves, and probably will always involve, managing symptoms of pain or anemia or breathlessness or oxygen shortage, and that looking at that aspect of management again is very important, but not something that I'll talk about a lot in this talk. So going on to the inhibition of hemoglobin S polymerization, which, as I said, in theory is quite simple. It's a simple chemical process where all the hemoglobin molecules stick together when they're deoxygenated. And if you could stop that, you would stop all the other problems in sickle, and all the pathological consequences flow from the polymerization of hemoglobin S to form fibers. This process has been studied, been known about for 50 odd years, and has been studied quite extensively. It's a two-stage process where there's a critical lag phase when deoxygenation happens, and then once polymerization starts, it proceeds very rapidly. The lag phase is very dependent on the oxygen concentration, the temperature, the pH, and also the concentration of the hemoglobin S level. And a very small reduction in hemoglobin S concentration causes quite a big change in the lag phase. There are different approaches to inhibiting hemoglobin S polymerization. There are the most widely used approach, which I'll come on to, is hemoglobin F inducers. Hemoglobin F doesn't polymerize, so by increasing the amount of hemoglobin F, you dilute out the amount of hemoglobin S. Additionally, when F is incorporated into a polymer, it ends the polymerization process, so it curtails it. And hydroxyurea is still the mainstay of treatment in sickle cell disease, and I'll talk a bit about that. There are many other drugs have tried to be developed to increase hemoglobin F, and to cut a long story short, none of them are in routine clinical use. Decitabine, which was an injectable drug, has been made orally available by the addition of tetrahydrouridine, which inhibits the gastrointestinal enzymes which break it down, and it seems to be a promising drug in development. It basically works, and the toxicity profile is acceptable, but it's still not a licensed drug. There have been various HDAC inhibitors do work, and pomalidomide and thalidomide also increase hemoglobin F levels, but again have not entered routine use. There's evidence that metformin may increase hemoglobin F levels, and there are phosphodiesterase E9 inhibitors, again, produced by a company called Imara, which do increase hemoglobin F. Again, these are all at the experimental or the clinical trial phase, and none of them are really particularly close to entering routine clinical use at the moment. The other approach that there's quite a lot of interest in at the moment is to increase the hemoglobin oxygen affinity, and one way of doing that is by decreasing the amount of 2,3-DPG in the red cells, which results in an increased hemoglobin oxygen affinity. This has really come about by drugs developed to treat pyruvate kinase deficiency, which activate the enzyme and lead to a reduction in 2,3-DPG. Mitapivat is the drug that's been used in PK deficiency and is now being studied together with another similar drug, etavopivat, for their role potentially in treating sickle cell disease, and they both look very promising, but again at very early stages. The market in Europe and the United States and other parts of the world. The other approach is to increase the amount of water in the red cell to dilute out the hemoglobin. And there are Gardos channel inhibitors and ferroportin inhibitors, which can do that, again, at early phases, and I'll mention those very briefly. Voxetor is the drug that most people have heard about. It's an orally active benzaldehyde derivative, which binds covalently to the N-terminal of the alpha-globin chains and locks the hemoglobin molecule in the oxygenated format. And the oxygenated format cannot polymerize, so polymerization is inhibited. Obviously, the downside of that is that the affected hemoglobin, the treated hemoglobin, doesn't release oxygen very readily. There've been one big trial performed of this drug, these are the early outcomes published in the New England Journal of Medicine a few years ago, showing that in more than a half people that have a significant increase in hemoglobin, in some cases going up to more than 4 grams per deciliter, and that there's a sustained mean at the higher doses of Voxelotor, there was a sustained increase of up to more than 1 gram per deciliter, sustained at 24 weeks. And subsequent extension of this trial have shown that this extends to 72 weeks without much fall off in effect, which is encouraging. The drug seems to be safe and well tolerated with relatively few side effects. And at high doses, as I said, the majority of people end up with reductions with increases in their hemoglobin level. The downside, and similarly, there's a reduction in hemolytic markers with about 20% reduction in reticulocytes and a smaller percentage reduction in LDH. The downside, so these are encouraging. What's difficult is quite knowing how useful this is. As mentioned, the Voxelotor increases the hemoglobin, the oxygen affinity of the hemoglobin, and in fact, the study suggests erythropoietin levels remain unchanged, meaning that you're not reducing the anemia, and you're not making it worse, but you're increasing the amount of hemoglobin, but that hemoglobin is not increasing oxygen delivery to the tissue. And the studies really have, the disappointing side of the studies is there's been no decrease in painful episodes or other symptoms of sickle cell disease, so it doesn't have any obvious symptomatic benefit, and there are no reported improvements in the quality of life. And so although it does increase hemoglobin, it's not exactly clear how useful that is and how valuable that is. There are arguments that these small reductions in hemolysis may be beneficial in the long term, and that the increase in hemoglobin in itself may be beneficial, although because oxygen delivery isn't improved, that's not necessarily a given fact, and ongoing clinical studies are needed to demonstrate the clinical benefits from this drug. At the moment, it's licensed in the United States and in Europe. Well, it's not fully licensed in Europe and it's not fully available, but the exact use and why it's being used is again emerging. Briefly, as I mentioned, red cell dehydration is a feature of sickle cell anemia. The sickle polymerase damage to red cell, and they lose lots of cations and water through the Gardos channels and the KCC channel. It is possible to inhibit these. KPOP is a Gardos channel inhibitor, and a bit like Voxelotor, it leads to quite a, like a 1 gram per deciliter increase in hemoglobin with a reduction in hemolysis. But the studies in that showed then increased, or at least no change in the frequency of acute pain, and the drug wasn't developed further. Similarly, magnesium is a way of preventing red cell dehydration, and a good study done looking at intravenous magnesium infusions to control acute pain in children in A&E showed no effect at all and no obvious benefit. Hydroxyurea is the drug that is widely used, and there's been around now, used in sickle since the 1990s with a lot of studies showing benefit. Almost every study that's been done has shown significant benefit. Recently, some big studies and some impressive studies have come out from sub-Saharan Africa. A study published in 2019, Russell Ware's the main author behind, or the final author behind both these studies, just looked at using a fairly low dose of hydroxyurea in an African setting. People had worried that in a country like Africa and other low-income countries where infectious disease is a problem, the possible immunosuppressive effects of hydroxyurea would be detrimental, and that things like malaria may be a barrier and it may make malaria worse. But in fact, the opposite was found. They showed in these African countries that there was compared to, it wasn't a randomized trial, but compared to the control period, there was a significant reduction in all complications, including acute pain, non-malarial infections, malaria, transfusion, and death. Again, from the same or similar group, a follow-up study really was trying to work out what's the best dose to give, whether you could give a fixed low dose or whether it was valuable to increase the dose as much as possible to the point at which the neutrophils start to fall. And so they compared the escalated dose with the fixed dose, and again found that there were benefits in both groups, but there were very significant benefits associated with the escalated higher dose, again with reductions in pain, acute chest syndrome, transfusions, and hospitalizations, suggesting really for the first time that, one, as we know, there's good evidence for hydroxyurea, but there is also good evidence for giving it at the so-called maximum tolerated dose. Then a lot of the work is really looking at treating the consequences, the downstream consequences of polymerization. Apart from hemoglobin F promotion, the other attempts are still experimental and have been largely unsuccessful. And I'll run through some of these very briefly. People have looked at reducing oxidative stress, anti-inflammatory drugs, the inhibition of adhesion molecules, antiplatelet agents, antithrombotic agents, and reducing hemoglobin toxicity using haptoglobin hemopexin. The three I'll talk about are Lglutamine, crizanlizumab, all those two, and Voxetor I've already discussed. There have been trials done of all these other things. Canakinumab had an early phase 1 study, is still showing promising results. Most of the others have shown either weak results in phase 1 studies and then negative results in phase 3 studies, or the phase 3 studies haven't yet been performed. Crizanlizumab is the drug, again, which has come to market in Europe, the States, and in other parts of the world. It's a P-selectin blocker given as an intravenous infusion once every 4 weeks. It's approved in the United States and Europe to reduce the frequency of painful episodes in children with sickle cell disease in adults rather, over the age of 16. And it costs approximately £100,000 a year in those countries, which is obviously a huge amount of money. This is the early results published in 2017 showing that at higher doses, the crizanlizumab did cause a reduction in episodes of acute pain. There are lots of things looked at, and all the vaso-occlusive complications were reduced by crizanlizumab significantly, but not in any sense curatively. But most of the effect came from the effect on acute painful episodes. The drug, as I say, is now just starting to being used in Europe. In the States, it has a clear role in the sense if someone has failed hydroxyurea, if they've taken hydroxyurea and not got a lot of symptomatic benefit, then starting hydroxyurea is another thing that can be done. Obviously, it's an expensive treatment, an intravenous treatment. It requires quite a lot of hospital resources, and quite how useful it will be in practice, again, is yet to emerge. Whether it helps with other complications other than pain, again, is information that may emerge in the future. Lglutamine is the other drug which is available in the States as a licensed treatment for sickle, but not in, as far as I know, in any other parts of the world. L-glutamine is an essential amino acid, and there's some evidence that red cells from people with sickle are short of L-glutamine and reducing power. It potentially has a therapeutic benefit by reducing oxidative stress. A phase 2 study showed a small, non-significant reduction in painful episodes, and a phase 3 study was performed, a fairly large study looking at children over the age of 5 over a 12-month period. And the primary endpoint was the number of painful episodes occurring over a 48-week period. And this was the result that of the 230 people enrolled, there was a clear benefit to L-glutamine in terms of reducing the number of painful episodes, but the number reduction was fairly small. It reduced it from a median of 4 to 3 per year. On this basis, it was approved by the FDA for use in sickle cell disease, but hasn't been approved in Europe because of concerns about the study, and in particular, the disproportionate number of dropouts in the L-glutamine arm compared to the placebo arm. And depending on how you account for this, you can lose the therapeutic benefit. So it hasn't been licensed in Europe, is available in the States. It's an expensive drug. Again, it costs £40,000 a year, as Indari, which is the pure form, although it is possible to buy L-glutamine in the UK and other places as a food supplement at a much cheaper price, although this is an impure form, and the company say, you'll then end up having a large number of impurities, which may cause problems. Stem cell transplantation, I'm not going to talk much about. It's still the only potentially curative option available. The indications are really regular transfusions or severe clinical course not responding to conventional management. The best outcomes are if there is a donor is an HLA identical sibling. And in the UK and in the States, about 10% of children have donors, only the majority, but families are fairly small and often have a complex structure. With HLA matched siblings, there's a 90% event-free survival, and 5% have a transplant-related mortality and a 5% graft failure. The main problems of graft-versus-host disease and infertility, the majority of children end up subfertile, which is a significant issue in some cases. Gene therapy is the other arm of stem cell transplantation, which is being developed. There are ongoing clinical trials using gene addition led by Bluebird Bio, and the early outcomes are encouraging, but subsequently less successful. And there's a feeling that as gene editing emerges, this approach will become less successful or less desirable. And then there's gene editing to either specifically correct the sickle mutation or to increase hemoglobin F synthesis. And this is at a very early stage, but again, there are some encouraging results emerging. This is from a recent study published last year, looking at editing BCL11A, whose production switches off hemoglobin F production. And by using CRISPR-Cas9 to inactivate the enhancer region of BCL11A, you can effectively stop the switch off of hemoglobin F. And this has been shown in the cell line showing that the edited lines produce far more hemoglobin F. And this has been reproduced in, I think, one patient so far. There are ongoing trials, and there are other different approaches targeting BCL11A mostly, or other factors which are known to inhibit or promote hemoglobin F production. And all of these look promising, but they're all at a very early phase 1 stage. The other approach, which seems to be the future, which I'll mention briefly, is directly correcting the sickle mutation rather than having to increase hemoglobin F levels to compensate for it. This has been difficult, but newer techniques such as base editing and prime editing allow that to be done much more effectively, and it seems likely that that is the future of stem cell therapy, of gene therapy, where it's all going. So at the moment, current optimal management involves neonatal screening, then prophylaxis against infection with penicillin V, antimalarials where appropriate, and vaccinations. Hydroxyurea probably should be given to everyone in the first few years of life. There's good evidence for that, and we should aim for the maximum tolerated dose. Primary stroke prevention should be offered, although in countries where safe blood transfusion is available, using transcranial Doppler screening. And then newer treatments have a relatively small role to play at the moment, but may emerge as they become cheaper and it becomes clearer how effective they are. Crizanlizumab there is a definite role if someone has continued pain or acute chest syndrome episodes despite hydroxyurea. Voxetor, as I said, its role is really unclear, but you can imagine if someone has significant symptomatic anemia with a hemoglobin less than 70 grams per litre, it may be helpful. And Lglutamine seems to be limited effectiveness, but maybe if someone has frequent pain and hydroxyurea failure. Stem cell transplantation at the moment, if there's a matched sibling donor, but that's switching towards using alternative donors with haplos or unrelated donors, although the outcomes for these are still not as good. In the next 5 years, it seems likely that escalated dose hydroxyurea will be prescribed or should be prescribed for all patients where the resources are available. Multi-drug therapy will become more of a thing when people can also have crizanlizumab and Voxetor and Lglutamine and maybe other drugs added, and stem cell transplantation if there is significant complications. And in 10 years, or maybe longer than 10 years, 10 to 20 to 30 years, the future probably is to have in vivo gene editing to correct the sickle mutation directly. So the technology for these two things, in vivo gene therapy and sickle mutation correction directly, is just beginning to emerge now, but it's already becoming possible in animals. And before seems very likely this will become a very important treatment in humans for sickle cell. The key thing with in vivo gene editing is that obviously you develop a vector in the laboratory which can directly correct the sickle mutation, and then rather having to take bone marrow out of someone, give them chemotherapy and put their own bone marrow back in, you can inject this directly into the body in the same way that you would a vaccine. It will target the hematopoietic stem cells and correct the sickle mutation in them. So it's a relatively simple, and although I'm sure it'll be very expensive, initially potentially quite cheap way of curing people from sickle cell disease. Before this is in widespread use across the world in sub-Saharan Africa, in India and Pakistan, then obviously there's a huge amount of things have to happen. But this seems likely to be where the treatments will end up. So in summary, early diagnosis and good clinical care continue to be the basis of management. Hydroxyurea should be given from an early age. There's likely to be 3 or more new treatments emerging in the next 5 years, raising the possibility of multi-drug therapy and increasing use of gene therapy over the next 10 years. Thank you.
Very informative talk by David Rees. Now we will move to next speaker, Professor Michael Angustinodis. He has been associated with numerous prestigious medical institutes for education and training. Until retirement, he was director of pediatric department of Archbishop Macquarie's 3 Hospital and the Thalassemia Center. Since 2004, he has been employed by TIF as medical advisor. He has been member of Thalassemia Control Program, and he has been member of Thalassemia Control Program and is vice president of Cyprus Society of Spastic Children. He is a chairman of Medical Record Committee. He is also a special advisor and consultant for the control of hemoglobinopathies in Eastern Mediterranean region. He is a member of board of directors of Cyprus Institute of Neurology and Genetics and WHO expert as advisory panel on human genetics. He has published great number of scientific articles, which mainly on hemoglobinopathies and thalassemia in particular. Professor Dr. Michael Angustinodis will talk about thalassemia management beyond iron chelation. Over to Professor Michael Angustinodis.
Good day, everybody. I'm Dr. Michael Angustinodis. I am a medical advisor to the Thalassemia International Federation, and I wish to thank the organizers for inviting me to say a few words about the future, if you like, of thalassemia and how we're hoping to treat it in the future. You will remember that the classical management of thalassemia depends on 2 main issues, blood transfusion and iron chelation, which of course are not enough by themselves. We need to monitor for organ damage. We need to detect organ damage early and minimize this by increasing iron chelation and other interventions. And of course, the only curative issue at the moment is hematopoietic stem cell transplantation. Now, this is what we have. Is this reaching everybody? As far as we know, something like 10 to 20% of patients globally do only benefit from adequate and safe blood transfusion. And even fewer patients benefit from adequate iron chelation. And very few escape organ damage, even when comprehensive care is available. And of course, health-related quality of life is possible for the few, but for most patients, this is difficult to achieve a good quality of life. We do need new approaches. We do need to reduce the need for blood transfusions. And I know that in Pakistan and in India, alternatives are being used by using hydroxyurea and thalidomide. But are they adequate? Are they really safe as alternatives? Do they guarantee the kind of outcomes that we want? Iron chelation is expensive and very difficult to adhere to on a daily basis. And of course, again, as I said before, these are not enough. Monitoring requires, for example, technologies like MRI, like multidisciplinary care. And the question is, are these available? And of course, organization, universal health coverage, is it available? If it's not, managing thalassemia is catastrophic, both for the family and sometimes for the state. So, and of course, psychosocial support, not very often there. So, are we really at the dawn of a new era? Well, yes, we are. There is some rays of light appearing on the horizon. There are curative treatments which have been approved. Gene therapy has been approved. Gene editing, not yet approved, but it's on its way. And of course, hematopoietic stem cell transplantation with alternative donors is increasingly being used with success as centers get experience. There are non-curative medications. For example, luspatercept, I'm going to talk about it, is already approved, and there are other pipeline drugs. And I'm only going to talk about a few very briefly that are at least in phase 2 trials. There are others not yet there. So what about gene therapy? Well, of course, the main approved gene therapy is one of gene addition. How does this work? Basically, we have a phase where the patient is given G-CSF, plerixafor, in order to mobilize hematopoietic stem cells from the bone marrow into the peripheral blood. These are collected and taken to the lab. In the lab, with the help of a lentivirus encoding a corrective copy of the beta globin gene, they are transduced, and new stem cells belonging to the patient are actually now able to produce the kind of hemoglobin that will actually help to correct the anemia and reduce ineffective erythropoiesis. In the meantime, while this is happening in the laboratory, the patient is given a myeloablative conditioning with busulfan usually. And once he's ready, then the cryopreserved stem cells are infused. And what we have is an available molecule, an available hemoglobin molecule, which is able to sustain a hemoglobin equal to or above 9 grams per dl, and even higher, which will ensure transfusion independence. As I said, this kind of approach has been approved. The company that actually promoted this named the drug Zynteglo, or the process Zynteglo, and a very high proportion of patients in phase 3 trials, there were about 300 or so patients entered in phase 3 trials, managed to maintain or achieve a hemoglobin of 9.5 or above, a mean of 11.7, quite satisfactory. There were 63 patients that went from phase 2, phase 1, phase 2, and through to phase 3. And there has been now, in some of these patients, up to 7 years follow-up. And as I said, transfusion independence was achieved in most of them. And over time, iron overload became less, and most managed to stop iron chelation in a couple of years later. The same approach, the same kind of treatment for sickle cell disease actually achieved in almost 100% of patients a reduction in vaso-occlusive crisis and the acute chest syndrome. So at least 49 patients have been treated and are now being followed up. Any adverse effects that have been experienced are not due to this treatment, but they are due to the myeloablation by busulfan, which means, of course, the usual, what we expect, stomatitis, febrile neutropenia, thrombocytopenia, etc. One worry, especially from the patients, is that busulfan may lead to long-term infertility, and this is something that we have to keep in mind. And as we keep in mind also the possibility of long-term malignancy. Zynteglo has been approved, but the expense is quite high. The treatment was put by the company at something like 1.7 million euros, and governments in Europe hesitated to approve this. And in fact, over 2 years, we didn't really have a full approval, and Zynteglo was withdrawn from Europe in 2021 and has now been shifted to the United States and is awaiting FDA approval. So the main side effect, the main obstacle to this treatment is cost. Nevertheless, long-term follow-up studies of the patients that have already been treated for a 13-year study will be ongoing to ensure that long-term safety is also available. What do patients think about this? TIFF surveyed about 850 patients, and as you will see in the bottom line, a very definite yes was offered by something like 41% of patients. A very definite no was only given by less than 4% of patients. And then the rest of 50-odd% of patients just hesitated for various reasons. So on the whole, the patient population is waiting for this curative treatment. Gene editing is a new approach. It's coming soon, we hope. It's still in early clinical trials, not yet available. What is gene editing? Basically, it's the use of enzymes, nucleases, which will cut parts of the DNA molecule, introduce, remove parts of the molecule, exchange, and through a process of homologous recombination, we will have a DNA molecule with a new sequence and function, which will hopefully give us the result that we want for our patients. And I will talk about the results at the moment. The kind of nucleases, just so that you remember the names, the zinc finger nucleases, the Talens, CRISPR, and others, which are available and being tried. This cartoon is one of the possible routes that CRISPR enzymes can give us. And basically, the DNA cutting enzymes will interfere with the double helix and give us either a new molecule or disarm a DNA sequence that we deem to be harmful. And for the majority of companies that are now in clinical trials, what they're doing is reactivating hemoglobin F, gamma globulin production, in other words. As you well know, hemoglobin F is a positive modifier. It restores globin chain balance, because the basis, of course, of the pathophysiology of sickle cell, of thalassemia, is this globin chain imbalance. The free alpha chains, which are impaired with the lack of beta chains, and the cause of cell apoptosis. So by inducing hemoglobin F, what we're doing is restoring this imbalance or replacing sickle cell hemoglobin. And one gene, which is the target of gene editing, is the BCL11A gene. It's a repressor of gamma globin production in postnatal life, and therefore by inhibiting this gene, we will increase hemoglobin F production. And as I said, this is the majority of clinical trials are actually using this methodology. There are other approaches. For example, in sickle cell disease, there is a trial, the CEDAR trial ongoing, in which it's not increasing hemoglobin F, but reducing hemoglobin S and restoring hemoglobin A expression. So this is something that we're waiting to see if it will work. Clinical trials have not yet started. So here we are with gene therapy approved, but not available. Gene editing on its way. What about medications? Okay, the medication that has been already approved in both FDA and the European Medicines Agency is a medication called luspatercept, which has now the commercial name Reblozyl. Now, this is an erythroid maturation agent. As you will see in the cartoon below, again, as a reminder, the early stages of red cell production are affected by erythropoietin, which multiplies the stem cells, but at a later stage, other processes help to mature these stem cells, and in fact, luspatercept encourages the maturation process and helps to give into the peripheral blood not fully matured and nucleated red cells, but red cells which belong to a rather younger age, if you like, of red cell maturation, of the red cell maturation process. It is approved for the treatment of anemia in adult patients with beta thalassemia who require regular blood transfusions. It's an easy drug to give. It's 1 milligram per kilogram given once every 3 weeks by subcutaneous injection. So that's quite a convenient methodology. If the patient does not achieve a reduction in the transfusion burden after at least 2 consecutive doses, then we increase the dose to a maximum of 1.25 milligrams per kilogram. There are side effects. The common ones are, of course, issues like fatigue, headache, musculoskeletal pain, joint pain, nausea, diarrhea, and others. Some patients that I have spoken to have had to stop treatment, usually for pain. There are, however, some serious consequences that need to be monitored. For example, thrombosis and thromboembolism. There is an increase in risk in beta thalassemia patients, especially those that are splenectomized. And this is something that has to be followed because it can have serious consequences, as you can well imagine. An increase in high blood pressure has been noted in some, and of course, embryo toxicity is a possibility, and we do not give in pregnant women or women intending to become pregnant. Now, in phase 3 trials, analyzing 224 patients, 45%, a little bit over half of the, a little bit less than half of these actually achieved what was the primary goal, which was at least a 33% reduction in the red cell transfusion burden over a 24-week period. There were secondary endpoints, for example, an extension to 48 weeks and either achieving a 33% reduction or a 50% reduction over the extended period. And this has been achieved over placebo. And of course, again, the iron overload is reduced over time, and it fell at least after 48 or so weeks. So Everything I have said referred to transfusion-dependent thalassemia. There are ongoing randomized trials in 145 patients over the age of 18 for non-transfusion-dependent thalassemia. The endpoint is to achieve an increase in the total hemoglobin of more than 1 gram per deciliter, and this should be achieved by 12 weeks, without, of course, the need for blood transfusion. And at the moment, it seems to be doing well, although final results are forthcoming, and have approval for NTDD is actually pending. But patients, as far as we know, are doing much better, are doing quite well. So in real life, Reblozyl is not beneficial to all patients. Around 20% do not respond or have abandoned treatment because of side effects. And there is currently no way to predict who will respond and who will not respond. So it's up to the clinician to decide to give the medication to his patients or to all patients and follow them up very carefully and see who responds, who does well, and who doesn't do well. Certainly, patients who do well believe that this is a miracle drug. Many of them have achieved even transfusion independence and actually swear by the drug that it's doing them extremely, it's changed their lives. The main side effect, of course, is cost again. A 25 milligram vial costs over 2,000 euros, and a 75 milligram vial costs over 10,000 euros. So if I was to have a 70 kilogram patient at 1 milligram per kilo, I would need 10,000 euros every 3 weeks, and of course much more if I had to increase the dose. Therefore, unless governments agree, this is, again, a treatment for the very few. Fortunately, it has had better luck in Europe than gene therapy, and several governments have actually approved of its use and are supporting patients who are taking it. And the same goes for the United States. Other drugs in the pipeline. I'm going to talk about mitapivat. It's being developed by a company called Agios. It activates pyruvate kinase and was originally planned for the treatment of pyruvate kinase deficiency. But of course, pyruvate kinase is important in the metabolism of red cells and red cell precursors in both thalassemia and sickle cell, and therefore it has moved into clinical trials for non-transfusion dependent thalassemia. At the moment, it's in a phase 2 clinical trial and has been shown to increase hemoglobin by more than 1 gram per dl in 80% of patients during the first 12 weeks. And it's not just beta thalassemia. 5 of them actually had hemoglobin H disease, alpha thalassemia. Phase 3 studies are planned and are about to start, both for transfusion-dependent and non-transfusion-dependent alpha and beta thalassemia. And of course, a phase 2 trial is being prepared, or at least has started, in 6 patients with sickle cell disease. And so far, things seem to be going well. Another drug, Imara, prepared by a company called Imara, Tovinotrin, it's now called. It blocks phosphodiesterase 9 inhibitor and activates hemoglobin F. So basically, it's a hemoglobin F inducing medication, which has entered ongoing phase 2b trials. And already, as far as we know, 35 out of 43 participants have completed at least 12 weeks of treatment. And of these 35, 19 have a severe beta 0 phenotype, and yet still seem to be responding well. So there are some side effects like all medications, including nausea, headache, and dizziness, but these are manageable as far as we know so far. So we're waiting actually for a final analysis of this phase 2b trial. In sickle cell disease, the issue is, of course, that we want to see a significant reduction in vaso-occlusive crisis, and this has indeed already been demonstrated in the sickle cell trial with or without the use of hydroxyurea concomitantly. So it has been shown already to be effective in sickle cell disease. Another medication is an oral ferroportin inhibitor, the aim of which is to improve iron metabolism and the production of red cells. Apologies. We have a phase 2 multi-center trial with 25 patients of non-transfusion dependent thalassemia, and a similar trial has just been initiated in December for transfusion dependent thalassemia. Again, the idea is to see the effect after 24 weeks of treatment. We don't have any results yet, but at least it's ongoing. And again, this medication should benefit sickle cell disease, and the phase 2 trial is also initiated. So just to remind us, in all these treatments, the treatments of the past and the treatments of the future, what do we want? We want a normal lifespan. Now, in high-income countries like the UK, like Greece, like Cyprus, what we have is an adult population, something like 20% are over the age of 50 and 60 at the moment of patients. So we are developing, or we have already, if you like, an elite group of fortunate patients. They do not represent the majority of patients in the world. What we need globally is to increase quality. And we increase quality by making sure of good patient outcomes. Morbidity and mortality reduced, quality of life increased. We need to look at governance and staffing. We need to see whether our patients are actually satisfied with what we're giving them. We need to look at evidence that that standards are being kept and that our patients are given psychosocial support. All these issues require registry and careful follow-up. And each one of us in our countries has to look at all this, has to be able to improve. Now, these treatments that I've spoken about actually will increase the inequalities because very few patients do have we have access in the near future. The Thalassemia International Federation has created a project called TIF Access with the aims of improving affordability, availability, and adoption by patients and governments, so that patients can actually get real access without being destroyed economically. In order to achieve all this, we need to target patients and increase their knowledge. We need to target healthcare professionals and increase their knowledge and convert them to advocates for their patients. We need to let the public know that new treatments are available. But most of all, we need to target policymakers, regulatory authorities, and manufacturers to keep the cost down. Just a reminder that the highest attainable standard of health is a fundamental right of every human being. And it's really a shame if some are benefiting from new therapies while the rest are standing by watching. So we need to work together to gain from these newly available therapies. Thank you for listening.
Thank you very much, Dr. Michael. Excellent overview for the thalassemia upcoming new innovative thalassemia management modalities. Now I would like to go to the next speaker, Major General retired Dr. Suhaib Ahmed. He's Professor of Hematology, Islamic International Medical College, Ripa International University, Islamabad, and he's CEO of Genetic Resource Center, Rawalpindi. Dr. Ahmed is a King Edward Medical graduate and Fellow of College of Physician and Surgeon. He completed his PhD from University College of London and served Armed Forces till 2012 at Armed Forces Institute of Pathology. He was awarded with Hilal-e-Imtiaz for his outstanding performance in medical field in 2012. His major diagnostic and research interests include molecular genetics of thalassemia, raising awareness about hemoglobinopathies, introduction of cost-effective prenatal diagnosis for the thalassemia couples in country. He has supervised several PhD and FCPS students, published over 50 research publications and several book chapters. Professor Dr. Suhaib will talk about diagnostic approach to hemoglobinopathies. How far have we come? Over to sir.
Assalamu alaikum. I'm Major General Suhaib Ahmed. I'm working as Professor of Hematology at Rifa International University, and I also head the Genetics Resource Center that specializes in diagnosis of genetic hemoglobin disorders. In this presentation, I'm going to talk about the diagnosis of genetic hemoglobin disorders in Pakistan in general, and then at the end we'll analyze that how far we have actually come. I think it's good at some point in time to look back and see where we are and how we can actually improve our overall performance. Just a brief history of hemoglobin disorders in this country. I think first patient of thalassemia was identified way back in 1960, and Rahim Tula in Karachi, she was the one who actually identified the patient. In those days, actually facilities for diagnosis of hemoglobin disorders were not adequate. In fact, they were very inadequate. And then in 1968, a publication by Sterner et al. From the city of Peshawar and its areas around, it showed that about 4% of the individuals they tested, they had thalassemia trait. So that was perhaps for the first time that we became aware that it's not an uncommon disorder. During the 1970s, generally the facilities, since they were not really adequate, so the awareness about the genetic hemoglobin disorders, it remained low. In 1980s, where actually I started my training in hematology at AFIP, I think the first thing I realized that thalassemia was a fairly common disorder. We had the facility for doing hemoglobin electrophoresis, and We were able to identify individuals with thalassemia trait as well as individuals who had thalassemia major. So with the passage of time, we became aware that thalassemia is one of the commonest hematological disorders that we see in our population. During the 1990s, I think that was an era when actually the molecular genetics and its analysis became possible in Pakistan. And I had the honor of introducing the prenatal diagnosis service for thalassemia for the first time in Pakistan. I think it was in 1994. During the 2000 and then later on, HPLC and capillary electrophoresis in particular, these two techniques, they became freely available. Although the instruments were costly, but generally that created a sort of a situation in which high quality and in bulk testing of genetic hemoglobin disorders that became possible. So overall, if we look at the genetic hemoglobin disorders in this country, about 90% of the problem is thalassemia. Whereas hemoglobin S and hemoglobin E disorders, they are also sort of not very uncommon, but rather less common disorders. Then you also see combination of thalassemias and these abnormal hemoglobins. Well, an important, I think, study that was published in New England Journal of Medicine, it showed that if you take index families of thalassemia, you are likely to get large number of carriers in those particular families. Maybe about 30% of the individuals in those families, they were carriers. As compared to that, if you do study of genetic hemoglobin disorders in families which apparently do not have any history of thalassemia or similarly a genetic hemoglobin disorder, they would perhaps show very little or maybe no carriers of thalassemia. So this actually led us to conclusion that in the population of Pakistan, it's not the 5% people who are actually carriers of thalassemia. It's perhaps 5 or maybe 10% of the families that are affected by thalassemia. So this was a very, very important sort of observation which actually led to the suggestion that if we want to do a mass carrier screening, then screening the index families perhaps would be the best choice. Well, as far as the diagnostic methods are concerned, we know that electrophoresis and HPLC, they form the basis of diagnosing the phenotypic type of thalassemias and other genetic hemoglobin disorders. But we also have the option of testing for the mutations which cause these disorders, and we call it genetic test. Electrophoresis most commonly used to be done with cellulose acetate membrane, and it's a very cheap, perhaps the cheapest method of doing electrophoresis. But unfortunately, since this is a manual method, it's labor intensive, it never became a very popular method. Gel bond with agarose electrophoresis, this is also available in the form of a kit, but it again is not a very popular method. Out of the electrophoresis, I think capillary electrophoresis has played a very important role in the mass population testing. And capillary electrophoresis is also available with us. Unfortunately, the equipment is also expensive, and it is also expensive to run. But nevertheless, it gives very precise results and is really very good. So cellulose acetate method, we know that it's a simple method, and we can identify the individual fractions. We can either inspect them visually, or we can test them by a densitometric method. In capillary electrophoresis, very thin board capillary actually transports the sample from one electrode to the other, and under very high voltage. And this process can be automated, and there is a laser detector which actually can detect the fractions as they pass in front of the detector window. And you get very precise, sharp peaks from where you can actually quantitatively estimate, and you can also know the quality of the abnormal hemoglobin that you're looking at. High performance liquid chromatography, HPLC, is also another very important method which can be automated, in which the colored compound like hemoglobin, it can be made to pass through a column of resin through which certain fractions they elute at different rates. And this process again can be automated, and we can know that what precisely we are looking at, the abnormal hemoglobin can be identified, and at the same time, it can be estimated quantitatively very accurately. Genetic testing is available, and polymerase chain reaction, I think that forms the basis of testing for thalassemia, known mutations, and amplification refractory mutation system, ARMS or ARMS, is the most popular technique because it is cheap and it can be reproduced, and it can be used for identification of known thalassemia mutations. Dot blot and restriction fragment length polymorphism, or RFLP, they are sometimes used but not very popular. Well, for detection of larger deletions like an alpha thalassemia, MLPA is useful, and gap PCR, they are also useful for that. Sanger sequencing is the method for identification of known and unknown mutations. There are some centers who are actually using Sanger sequencing for analysis of thalassemia mutations, but it is rather more expensive. Well, we have developed a multiplex arms PCR, and 3 combination of primers can actually identify almost 90% or 95% of the mutations that prevail in our population. It's a very, very cost-effective method, and for practical purposes, for identification of mutations in our patients, at my lab, I routinely use this multiplex PCR. This study was published way back in 1996, where we were able to identify the thalassemia defects or the genetic defects or the variants in different ethnic populations. These are some of the common mutations, and similarly, we also know that there are certain uncommon and rare mutations, and this actually provided us a basis for doing prenatal diagnosis in our population. As you can see here, that there is a remarkable difference between the prevalence of common mutations like IVS15. It's not very common in the Pathan population, whereas in the Baluch population, nearly 3/4 of the patients, they have IVS15 mutation. And frameshift 8-9, another very common mutation, it's more common in Pathans and less common in Sindhis and Baluch population. Well, just a summary of the application of PCR in genetic hemoglobin disorders. Most important application, of course, is prenatal diagnosis, and we are routinely using it for that purpose, because when we take the fetal sample, it's basically the fetal DNA, and you can't use any other test other than the PCR. Then diagnosis in previously transfused patients, this is also very important, that when it becomes obscure and when the parents are not available because of the recent blood transfusions, we know that we have to resort to genetic testing. Then there are certain types of thalassemia carriers who can be identified only by PCR, for example, CAP1 mutation, or the silent carriers, or the carriers of even alpha thalassemia. Then distinction between structural variants and thalassemia intermedia, alpha thalassemia, etc. These are some of the indications for doing genesis. Well, now coming back to that summary, actually, this is the crux of the matter, that how far we have actually come. This is, I think, a couple of slides, they're really important. Number one, genetic hemoglobin disorders are the commonest genetic disorders in Pakistan. Rest assured that this is the commonest genetic disorder, thalassemia and other abnormal hemoglobins. And we have almost every diagnostic modality in our armory. And we know that we can use HPLC, we know we can use manual method of electrophoresis, by cellular-assisted membrane electrophoresis, and we also have capillary electrophoresis. And then on top of that, we also have the facilities for genetic analysis. Although these facilities are not really widely distributed, generally the genetic testing is available only at few places, but HPLC and capillary electrophoresis and maybe even manual electrophoresis method, they are rather available at larger labs. Thalassemia carrier screening is still limited to the large labs only. I think this is the bad part of it, that we have not been able to extend our services to the smaller labs, and that's an area where we need to work. Fortunately, many of the large labs, they have got large number of collection points all over the country, and people can avail those facilities, but the price is high. For the common man, I think we need to have either the subsidized cost because it's a very common disorder, and it's an extremely important test to know if you're a carrier or not. If one wants to know about the status before marriage, then I think the test should be available, and it should be available freely or at a very subsidized cost. I'm glad that Punjab Thalassemia Prevention Program, they're offering free of cost testing for carrier screening and prenatal diagnosis as well. Well, most diagnostic tests are done on automated equipment. Manual testing, although is very cheap, but is underutilized. I think this is another area where we need to work. We need to provide cost-effective methods like manual testing, which may be labor-intensive, but we know that the labor is not expensive in this country, and these methods are underutilized, and they should be encouraged. Well, another important fact which I have observed, that almost 1/3 of the patients who come to the lab for diagnosis, they have already received blood transfusion. Well, that makes the scenario very complicated. Although it is not in our hands, but I think it's important, especially when you're testing just the blood samples and without looking at the patients. It may create an embarrassing situation in which a patient or a child may be chronically transfusion dependent, and if his or her blood sample comes to the lab and without looking at the patient or even knowing the history, you run the electrophoresis, HPLC or whatever, you'll get a normal result. So that can lead to a very, very sort of embarrassing situation, and I've seen such things happening in front of us. A significant number of THAL patients remain undiagnosed. Well, again, very unfortunate part. Even today, with the state-of-the-art facilities available, there are significant number of patients who remain undiagnosed. Unfortunate. I think it's rather unfortunate that at many of the treatment centers, there are patients who are chronically getting blood transfusions, and they are not in fact THAL patients. They may be having red cell aplasia, sideroblastic anemia, or even congenital dyserythropoietic anemias. They all get blood transfusions and chronic blood transfusions, and they are known as thalassemia patients. Many times, such parents, they are referred to me for prenatal diagnosis, and on testing, we come to know that this is not thalassemia. So that becomes a disappointing sort of a scenario for the parents, especially when they come to know that prenatal diagnosis cannot be offered in this particular scenario. Well, PCR is a very useful facility, but I'm really disappointed to know that most of the PCR being done for thalassemia, they are used for predicting response to hydroxyurea and some other funny drugs. Well, that I think is not really required, but unfortunately, this virus has spread so rapidly and rampantly that it's really very, very difficult now to convince people that PCR is not required for predicting response to hydroxyurea especially. People think that there are certain mutations in which the patient would respond better to hydroxyurea. Well, it is not the case. Let me tell you that if they resort to testing for XMN1 polymorphism, that is a more useful test if you want to know whether the person would respond to hydroxyurea or not. This test is grossly underutilized, the XMN1 polymorphism. Instead of mutation testing, I think we need to do XMN1 polymorphism testing. That again is a PCR based. Well, rather, second part of the story is that in prevention side, prenatal diagnosis of thalassemia is available since 1994. The service was introduced in 1994, and today I know there are at least 5 or 6 labs in this country who are doing prenatal diagnosis of thalassemia. It's good to know that. But the unfortunate part is that almost all of the children with thalassemia major seen today, they were born at a time when prenatal diagnosis was available. Unfortunate, very unfortunate. If we know that there are 50,000 patients of thalassemia major today, rest assured, they were all born during the last 20 or 25 years, and that's it. So that was the time when prenatal diagnosis was also available. It's really, really unfortunate. So we need to actually extend our services. I have estimated that it's only about 10% of the couples at risk of thalassemia who request prenatal diagnosis, and nearly half of these patients have already used the test. Well, it's very unfortunate. So that means there are about 90% of the couples at risk. They either remain ignorant of the risk or are unable to use prenatal diagnosis. I think this is an area where we need to work the most. We need to increase the availability of prenatal diagnosis, because ultimately it is the prenatal diagnosis and perhaps carrier screening which is going to eliminate thalassemia from our community. And if we don't realize that at this point in time, maybe another 20 or 30 years, we will still be rather in a frustrated situation that why we have not been able to increase the uptake of this and that. But this is an area where I think we need to work on this. A lot of work is rather required. Ignorance, logistics, and cost are the three most significant impediments to prenatal diagnosis. We need to work on all three areas. My final slide. Well, prenatal diagnosis was introduced in 1994, and by year 2021, we are now nearly doing 2,500 prenatal diagnoses every year. But this number is not enough. Let me tell you, although on this slide the progress seems very impressive, but rest assured, this is just the tip of the iceberg. We need to extend our service for prenatal diagnosis many times. And similarly, the diagnosis of thalassemia, both of the carriers and thalassemia major, that is also important. Especially the carrier screening facilities, they must be made available at smaller labs if we really want to do something for prevention of thalassemia. Because I know that postnatal diagnosis of thalassemia perhaps is not a big issue. It can be done. So what we really want to know is that before marriage, the carrier screening, that's important. And secondly, the individuals who've got already affected children with thalassemia, they need to be given prenatal diagnosis, I think. This is the most important message that I wanted to get. At the end, I would like to thank the Pakistan Society of Haematology for giving me this opportunity to share with you some of the thoughts. Thank you very much.
Thank you very much, Professor Dr. General Retired Dr. Suhaib Ahmed. Excellent and thought-provoking talk. And before moving on to the next speaker, I would like to comment and announce that we are taking questions from regarding talks. So kindly post questions. So we will discuss these questions in Q&A session. Our next speaker is Professor Dr. Nisar Ahmed. He is Professor of Hematology, Oncology, and Transfusion Medicine, Bone Marrow Transplant, the Children's Hospital and Institute of Child Health, Lahore. He is a fellow of College of Physician and Surgeon. His major diagnostic, clinical, and research interests includes a wide range of topics: hemoglobinopathies, hemophilia, thrombophilia, platelet disorder, red cell disorder, myelodysplastic syndrome, inherited disorder among neonates, toddlers, and pediatric population. He has over 60 national and international publications under his name and has mentored more than 60 FCPS students. He will be talking about anemia of infancy, a local perspective.
Bismillahir-Rahmanir-Rahim. First of all, my special thanks to the organizing committee for providing me this opportunity to share my experience, that is anemia of infancy, with you. As you know, me is a pediatric hematologist, and I am working in the Children's Hospital for the last 27 years. So pediatric hematology, in particularly anemia of infancy, is very close to my heart. So basically, this presentation, we will outline the different aspects of anemia of infancy. And my special presentation is for the PGRs, because they are the budding hematologists and they are the future of our hematology. So most of the presentation points will be related to my PGR students. So first of all, what are the goals of this presentation? I think at the end of presentation, all the attendees, especially the PGRs, they will be able to understand the anemia of infancy, what are different types of anemia, what are different presentation, diagnosis, and management, and of course, the most important part which we'll discuss at the end is what is local and international perspectives of anemia of infancy. My presentation outline will be very simple. First of all, I will give you some clinical scenarios so you can understand what are the different presentation of anemia in infancy, and then how you evaluate these the cases by the gold standard, that is history, physical examination, lab investigation, and management. And in the end, we will summarize what we have discussed, and at the end of the presentation, you can have the different questions. I think before we discuss the scenarios, the most important thing is one should know what is physiologic anemia. Basically, it's anemia of early infancy. It's a most common cause of anemia in infancy. Basically, it can from birth to 3 months, but actually 6 to 9 weeks of age, because of the physiological decrease in erythropoiesis due to increased tissue oxygenation and decreased production of EPO, we have the physiological anemia. And most of the time, in the healthy individuals, this physiologic anemia or anemia of early infancy is unnoticed. But in premature infants, low birth weight infants, and very low birth weight infants, this can be a clinical diagnosis. So we have to be very careful during this time. We can have physiological anemia. I think before we discuss the anemia of infancy, I will have the free clinical scenario so you can understand what are the different presentation and what at what different ages patient can present with different types of anemia. Classically, this is a first scenario: a 5 days old male baby born at home presented to emergency department for irritability, progressive yellowness of eyes. This is a classical case presented in our neonatology units. On examination, patient was having pale yellow sclera and mild splenomegaly. And when you have the CBC, classically hemoglobin is low, WBC 17.9, platelet again, and MCV is very high. This is the classical presentation and a very common presentation in our neonatology unit. That is a hemolytic disease of newborn, this patient. And this is one of the most common presentation in our neonatal unit. So we will discuss later on. Second scenario again, 1 week old baby referred to pediatric hematology clinic for evaluation of anemia. On examination, baby was pale with jaundice and splenomegaly. CBC revealed hemoglobin 7.7, MCV 102, WBC 9.7, platelet again is very low. But when you see the blood film, it's a macrocytic without nucleated RBC and polychromasia. This is again a very common presentation in pediatric units, especially in neonatology. It turned out to be a pure red cell aplasia. We will discuss later on, but I am just giving you the different scenarios. This is again a very common scenario. Look at the age. A 6-month-old female infant referred to pediatrician for evaluation of failure to thrive and marked pallor. On examination, they were pale, they were hepatosplenomegaly and mild jaundice. And when you have the CBC, you can see a low hemoglobin 6.1, WBC 12.1, platelet 375, MCV is very low, MCH is very low, that is 18.1. This is again a classical presentation of beta thalassemia major. And you know, in our setup where we have very high 6 to 8% of thalassemia trait in our population, and still we have the cousin marriages in our setup. So you have a lot of cases, especially at the age around 6 months of thalassemia major. This is again a very classic presentation in our setup. A 7-month-old breastfed female male infant presented to pediatric hematology clinic for evaluation of paleness. Patient have pale. On examination, patient was pale without evidence of jaundice and hepatosplenomegaly. And when you look at CBC, low hemoglobin and low MCV, again, this is the classical presentation, and this is most common cause of anemia in infancy. That is, at this stage, when there's weaning is there and there's no iron supplementation, food fortification, patients suffer from the iron deficiency anemia. Again, I think even in our setup or in the international studies, this is the most common cause of anemia in infancy. Again, this is again a presentation at the pediatric hospital is very common. A 9-month-old male infant referred by family physician for patient for failure to thrive and pallor. On examination, patient was pale without jaundice and paracetamol. Look at the CBC again, low hemoglobin, WBC platelet are normal, MCV 99, and rating is very low. This is again a classical example of congenital dyserythropoietic anemia. We will discuss. Now you can imagine looking at the age, presentation, the hemoglobin, rating, and MCV. You can diagnose different types of anemia in infants. Today, I am going to focus on mainly the diagnosis or evaluation of any case presented in infancy. That is right from day 1 to 1 year of age, which is known as infancy. And I'm going to discuss those points which usually are neglected when you are looking these patients. So irrespective whether you are a diagnostic hematologist or a clinical hematologist, I think the diagnosis, the evaluation of anemia is very important. And it's only if I will focus mostly on those points which are usually missed in our discussion or in our training programs. The gold standard for any clinical diagnosis, I think, is same, whether you are working any specialty, that is history, physical examination, and laboratory evaluation. These are 3 fundamental pillars in diagnosis or evaluation of any patient in any clinical specialty. Look at the age. If you have the the age, for example, in neonates and young infants in first 3 months of life, mostly the diagnosis of patient presented with immune diseases, purered dysplasia, or inherited or hereditary disorders. Anemia detected at 3 to 6 months of age. Again, classically in our setup, we have the hemoglobinopathies, thalassemia, and in older infants, when weaning is there and fortification of if food is not there, we have the iron deficiency anemia. Again, you should know whether you are dealing with the male baby or female baby, because X-linked sideroblastic anemia, X-linked G6PD in females. Again, symptoms, when you take the history and you evaluate symptoms, it's again a very important. And you should ask about the changes in urine color, which will do towards the immunity disorders. Similar bleeding disorder, bleeding history patient can present with iron deficiency anemia. Infections, infectious history will tell you about the infectious etiology. I think in infant, the dietary history is very, very important. Without taking a dietary history, you can't diagnose these. For example, infant, iron deficiency is suggested by due to low iron formula, introduction of cow milk before 1 year, excessive milk intake because iron is low in milk. So poor intake of iron-rich foods again will tell you this could be a case of iron deficiency anemia, because in iron deficiency anemia is one of the most important cause of anemia, not in our setup, even in the Western countries as well. A travel history again, you must ask about your travel history, because infections, suggestive infectious etiology, malaria, hookworm, tuberculosis, all these are important. Again, we most of the time we are missing the developmental history. Working in a children's hospital, we have come to know that this is again a very important clue for the diagnosis of different types of anemia in infancy. For example, developmental delay is associated with iron deficiency anemia, B12, folate deficiency. We have seen in anemia, even in thalassemias. So you should take the development history proper in this patient. Similar, if there is, you should have the prior episode of anemia if it indicates inherited disorders. Anemia with the previous normal CBC will show the acquired etiology. If you have the hyperbilirubinemia in newborn, of course, this is a case of hemolytic disease of similar underlying conditions like inflammation, autoimmune disease, infection, renal disease are important part in the evaluation of the anemia infancy. Similar drugs and toxins, for example, in infancy, anemia following exposure to oxygen drugs, fevabine deficiencies, exposure to pain, home renovation, lead toxicity, very common cause of anemia in infancy. I think one can't forget to get the history, family history, because the family history is again a very important in cases of anemia of infancy. When you have family history of jaundice, gallstones, splenomegaly, surgery, it indicates towards the inherited hemolytic anemias. And when you have taken the complete history, I think that the most important part is the physical examination. And without doing physical examination, you can't reach the final diagnosis. Again, in hematology practice, the most important part is to see the pallor, the jaundice, splenomegaly, lymphadenopathy. All these features help in the differential diagnosis of anemia of infancy. Of course, skin is again a very important organ. While examining skin, different types of anemia you can pick from the skin. For example, if the hyperpigmentation or hypopigmentation is more common in cases of anemias. Similarly, hyperautoimmune hemolytic anemia, thrombocytopenia, bone marrow failure will show the symptom of the low platelets. Similar, if you can find yellowness of sclera on the tongue, hemolysis there. Similar in cavernous hemangioma, you are defining the microangiopathic hemolytic anemia. Ulcers, again, a very important clue for the hemoglobinopathy, especially sickle cell disease. Similar, we have seen a different type of phases, especially in thalassemias, for frontal bossing, prominence of malar, maxilla, thalassemic syndrome is there. Eyes, again, but very important because the phencylaemia can present in the early ages. We have seen patients even presented in the infancy. A similar history of blindness, we suspect osteopetrosis. When you have vitreous retinal hemorrhages, sickle cell disease is similar. If you have seen the cataract, it's very common G6PD anguloctosemias. Similar, at the same time, you examine the mouth, showing glossitis, angular stomatitis in B12 iron deficiency. If you have tripharyngeal thumbs, you can have phencylaemia or PRCA, spoon nails, iron deficiency anemia. When you have shield chest, you have divergent leukemias. If you have the hepatosplenomegaly and WBCM platelets are also disturbed, you look at the leukemia or the infection. So it means every organ is important. Now comes to the most important part as a hematologist when you are working in the lab. I think simple screening by having the complete blood count, red cell indices, blood film, and reticulocyte count, you can diagnose almost 99% cases of anemia in infancy. And of course, when you have the provisional diagnosis, then you go for a specific test, which are LFTs, LDH, DAT, enzyme assay, hemoglobinopathies, bone marrow biopsies, genetic and molecular studies. But these are confirmatory or specific tests when you have the provisional diagnosis to any disease. First, we will talk about the neonatal anemia. And because in the first month of life, a patient can present it with anemia. And in our setup, we have the largest neonatal unit in our hospital. So we have a lot of cases of neonatal anemia in our setup. And again, very simple approach. We can have neonatal anemia due to reduced red cell production, that is aplasia or hyperproliferative, increased red cell destruction, that is hemolytic anemia, and blood loss. In neonatal anemias, the most important cause, which is when you have reduced red cell production, that aplasia, the causes you can see in your screen: parvo beta B19 virus infection, prematurity, genetic red cell aplasia, alloimmune antibodies, or CDA. These are the very important cause of neonatal anemia in our setup. We will discuss later on. For example, and I will discuss only those cases of anemia of infancy which are less discussed in our meetings or in the scientific sessions, because we have lot of discussion of iron deficiency anemia, thalassemia. So I am not going to discuss in detail the thalassemias, iron deficiency anemia, or others. I will focus those diseases which are less discussed in our clinical meetings. For example, congenital pure blood aplasia, which is known as diamond black anemia, the incidence is 5 to 7 million per million at birth. 40% have family history, and 60% are sporadic, which means there was no family history. Mostly it's autosomal dominant, but autosomal recessive is also there. And 50% are associated with congenital anomalies. And when you look at the blood film, this is macrocytic, normochromic, without polychromasia and nucleated red cells. Reticulocytopenia is again very low or absent red cell precursors in bone marrow, increased red cell ADA levels, and elevated hemoglobin F levels, mutation in ribosomal protein, that is ribosomal protein, small and large subunits. And you have to differentiate of this pure red cell aplasia from the phenylketonuria, transient erythroblastopenia of childhood, and parvovirus 19. Of course, treatment we will discuss, that is red cell transfusion, corticosteroid, hematopoietic stem cell transplant, gene therapy is there. And this is the most important part, because when you have the pure red cell aplasia, you have to differentiate whether you are dealing with the diamond black anemia or transient erythroblastopenia of childhood. And you can see the DBA, the median age is 2 months, while TEC is more than 1 year. Inheritance, you can say sporadic or dominantly 45, while TEC is not inherited. Congenital anomalies, you can see 50% cases of DBA, which is known in TEC. Similar, erythroblastopenia is present both. Hemoglobin levels low is both in both conditions. Reticulocyte is low in those conditions. But look at the MCV, ADA level, hemoglobin F, and ribosomal protein gene mutation. All these are in DBA, but all these conditions are normal in case of TEC. So the diagnostic criteria is again very simple. Age is less than 1 year. Macrocytic anemia, reticulocytopenia, normal marrow cellularity with reduced erythropoietic precursor. Now they have the spotting criteria, which is major is gene mutation, positive family history, and minor is elevated adenosine amylase level, congenital anomaly, elevated hemoglobin F, and no evidence of other inherited bone marrow failure syndrome. I think the one of the largest study from Pakistan have been published recently in the Pediatric Hematology Oncology Journal 2020. It's a 10 years experience. They have reviewed 19,475 cases, and they found 74 patients, that is 4.4% patient presented with the pure aplasia. A mean age was 5 months, male female ratio was 4.2 into 1, and they have found 23% family history, 34% with congenital anomalies, and hemoglobin range was 2.5 to 6.5, hemoglobin 0.5 to RBC 0.5 to 3, and hemoglobin F 2 to 20%. So this is the I think largest study from Pakistan, from the Children's Hospital Lahore. Similar, I found one study from the Pakistan Journal of Medicine and Health Sciences, published by the Nisar Ahmed, and they have seen the in 5-year study they study 1,800 children, and they found that 91% have iron deficiency anemia, 6.6% hemolytic anemias, and they found 1.6% in pure red cell aplasia, and 0.4% CDA, and 0.1% SA. And when they split the pure red cell aplasia, they divided that 80% are diabetic anemia and 7% are transient thrombocytopenia of childhood. And one again study regarding the role of steroid in the management of PRCA. They 30 patients, and they have given 1 milligram per kg per day, and they found that for 50% patients respond to the steroid. My personal experience in last so many years is nowadays even steroids, when you start after 1 year, because we never start the steroid in the early ages because of the developmental depression and developmental delays. So in first year, we manage the patient with the red cell transfusion, and after 1 year, we start the steroids. Our experience is excellent. 70 to 80% of patients respond to these steroids, and partial response patient can be added with the cyclosporine as well. So quickly about the increased red cell destruction, that is hemolytic anemias. Again, a very common cause of neonatal anemia, and we have seen hemolysis of fetus and newborn, red cell membrane disorder, red cell enzyme deficiency, hemoglobinopathies, but these are rare. Usually we see the hemolysis of newborn in our setup. And we know elimination against the reserve blood group, Cal, Kid, Duffy, MNS, and diagnostic criteria is again very simple. Whenever patient presenting in neonatal age, we have the low hemoglobin with reticulocytosis, nucleated red cells, unconjugated hypobilirubinemia, direct home-start positive, and increased LDH. Diagnosis is very simple, and management is again simple. But this is a very simple algorithm for the neonatal anemia. That is, whenever you have to decrease hemoglobin, go to the reticulocyte count. If it is low, you are dealing with red cell aplasia. If it's raised, do the that positive test, which is known as hemolysis of fetus newborn. If negative, and then go for the MCV, you will have the membranopathy, hemopathy, blood loss, MCV low, thalassemia, or the hereditary pyropyrocytosis. And this is again a very common presentation in our setup, that is anemia of infancy. That is congenital dyserythropoietic anemias. These are the heterogeneous group of conditions which are characterized by ineffective erythropoiesis, anemia, multinuclear erythroid precursors, and excess iron in the store. There are different types of CDA, there CDA 1, 2, 3, 4, 5, 6, and you have to differentiate from the hemoglobinopathies, the sideroblastic Geta mutation, and MPS. Again, this is again you must have seen there are 3 types of the CDAs, and most of these are diagnosed on the basis of bone marrow morphology and serology, and of course the gene analysis. Just and treatment is very simple. Usually, in most of the cases, when hemoglobin is 7 to 8 or more than 8, we don't do any major intervention. and folate supplementation, red cell transfusion, iron chelation, splenectomy, interferon, and of course, resistant cases, hematopoietic stem cells is there. And there is again a very large study published in the Pakistan Pediatric Journal by Samina Farhan and Nisar Ahmed. They have 10-year, 12-year period, and 31 children were examined, and 20 children have the CDA type 1, and 11 children have the CDA type 1. No case was of CDA 3 was presented in this stage. And the most important thing is they have compared with their data with the international CDA histories. And you can see from your table, in our setup, the patient presented with very low hemoglobin, that is 4.3. And red cell count is also very low in our setup. Similar, the MCV was very high. Reticulocyte count in our cases were high as compared to the international history, and bilirubin was also very high in case of our setup. And this is a very simple, very practical approach for diagnosis of algorithm of anemia in infancy. That is, whenever patient presented with infancy, low hemoglobin, just do the MCV. If it's low, go retic count. If retic count is normal or decreased, it's iron deficiency. If it's increased, thalassemia. If MCV is normal and retic count is decreased, it is CDA. And if it is increased, these are the hemolytic anemias. Similar, increased MCV, you have the increased retic, that is autoimmune hemolytic anemias, and low folate deficiency and phenylketonemia. So management of infancy is very simple, depending upon the underlying etiology. These are different modalities: red cell transfusion, corticosteroid, hematinics, treatment of underlying condition, hematopoietic cell transplant, gene therapy. So all these are. So this is a very important slide. I have taken from the Children's Hospital. They did the bone marrow of patients referred for the anemia of infancy. And this is data of 2021. You can see acute leukemia was the most important cause of anemia in infancy. There are 27 cases, but these are the bone marrow patients. Patients referred for the anemia for the bone marrow. You can see third hyperplasia, that is hemolytic anemia in 24 patients, hemophagocytic 22, pure red cell plasia 13, megaloblastic 9, stoichioid disease 9, MDS 9, osteopetrosis, and sideroblastic anemia share is there. So to summarize my presentation, thalassemia of infancy, that is the threshold for defining anemia is hemoglobin hematocrit, that is less than 2.5 percentile for the age, sex, and race of the patient. And gold standard, again, why I'm stressing, the gold standard for evaluation is proper history, proper physical examination, and screening test, that is complete blood count, retic count, blood film. Again, in our setup, considering the age in neonate, we have the hereditary and inherited causes are there. That is hemorrhages of fetus or newborn, pure red cell plasia. In infancy, acquired causes like thalassemia, RDA, CDA. These are patients presented more than 6 months of age. So I will stop here. If you have any question, I will answer those questions. Thank you very much.
Thank you very much, Dr. Nisar. Moving on to panel discussion for session. Before panel discussion, I would like to introduce renowned hematologists that are included in our panel to cater the questions. First panelist she's well-known hematologist, Dr. Samina Tufail. She's currently working as a consultant hematologist at SALMC Hematology Clinic. She was previously at HOD Pathology Department of Pakistan Atomic Energy Commission General Hospital, Islamabad. She has more than 30 publications in national and in international journals. Our second panelist is a distinguished hematologist, Professor Shahtaj Khan. She is currently working as in charge pathology department in Hayatabad Medical Complex, Peshawar. She is a program director for Diploma in Clinical Pathology and FCPS Hematology. Dr. Khan has published more than 26 articles in national and international journals. Our very seasoned hematologist, Dr. Saqib Ansari, is also on our panel. He has more than 20 years experience of pediatric hematology. He is founder of Children's Hospital Karachi Research Institute for Blood Genetics and Bone Marrow Transplant. He is general secretary of Umair Sana Foundation. He has more than 60 national and international publications and supervised multiple MPhil and PhDs. Dr. Ansari served as member of pioneer team of bone marrow transplant unit at Bismillah Taqi Institute of Health Sciences and Blood Diseases. I welcome all the panelists, and before we go on to the panel discussion, I have one question that I want to forward to Professor Dr. Suhaib. Is Dr. Suhaib is connected? Sir, there's a question.
Yes, I can hear you.
Okay, thank you. Should we do a PCR? Someone asked, should we go for PCR testing for screening when a patient is on hydroxyurea to see the response for hydroxyurea?
Well, I have my own point of view, although people may not agree to that. But frankly speaking, I don't find any association between, or for that matter, very, very little association between particular type of a mutation and response to hydroxyurea. In fact, what people have misinterpreted is that there are certain mutations that are strongly linked with XMN1 polymorphism. For example, splice site mutations, IVS15, IVS11, codon 30, these are all splice site mutations, and similarly hemoglobin E. No, it is not these mutations which actually respond better to hydroxyurea. It is their association with XMN1 polymorphism that makes them more likely to respond to hydroxyurea. So instead of doing mutation analysis, I would strongly recommend that you should go for XMN1 polymorphism. If there is a particular patient who has got a milder disease and has XMN1 polymorphism, well, I think this is a strong candidate for giving hydroxyurea. Doing the mutation analysis, of course, is expensive, but some or the other people are now convinced that it is the mutation, it's not the XMN1 polymorphism. Well, the scientific basis, I have told you, this is what it is. Thank you.
Thank you, Professor Dr. Suhaib. I have one other question. I would like to forward this question to Dr. Saqib Ansari, as he is doing clinical pediatric hematology. Dr. Saqib, there's a question: how frequently one should do echocardiography to be for monitoring the treatment of thalassemia patient?
Thank you very much. First of all, my salam and hello to all my colleagues. Are you listening me? Is it okay?
Yes, we can hear you.
Great. So, in fact, there was some confusion. Question which was first asked should be with me as well. So I will come to it on second phase. It's not really working very good echocardiography. I have seen the patients terminally ill and they have developed cardiac failure. Until the end, their echo was fine. The echo was fine till 1 month back, but within last 30 days, the most relevant thing is arrhythmias. Those thalassemic patients who have developed arrhythmias, they should be, this is an alarming condition, and keep an eye on cardiac arrhythmias, number one, and number two is cardiac QT star MRI should be developed in different part of the country as well, because it has got more association, it is more associated with cardiac function, and rather than echo, in my personal experience, there's no role of echo. Number two, I totally agree with Professor Suhaib Saab. Genetic mutation like polymorphism, XMN1 polymorphism is 40% present in our population of thalassemics as we published it, and 70% of those 40% are responders to hydroxyurea. So yes, excellent polymorphism is important to find out in our 40% population of the thalassemia in Pakistan. Whereas, as he said, that in our published data, recently the paper we published in Pediatric Journal of Hematology Oncology, and more than 600 patients have been studied in different studies published by our group for last 20 years. IBS1 position 1, CD30, 90% responder, even they are XMN negative. And I can, sir, my respected professor Suhaib always have concerns that those who are carrying these genes are XMN1 positive, but even they are XMN1 negative, they are still responder to hydroxyurea if they are carrying CD30 mutation and IBS1. Thank you very much.
Thank you, Dr. Saqib. I have one more question. Let's start the panel discussion. I have one more question I'll direct to you. There are new emerging treatment modalities available for sickle cell and thalassemia patient. Would you please comment how effective are these agents, cost and in terms of cost and benefit ratio and quality of life of patient?
As my honorable speakers and those who have already discussed for last 2 hours in detail, all these things in detail, and they themselves, what they have concluded, I'm repeating it. Luspatercept, A New Hope, a lot of adult patients are visiting us, there's a new medicine. What they said in their recent New England Journal of Medicine's paper, 33% reduction in blood transfusion requirement, and those who require 12 blood transfusions a year, it reduces to 9 blood transfusions a year or 10 blood transfusion a year. And it costs 10,000 euro every 3 weeks. So 20 lakh rupees every 3 weeks. So out of question, even it becomes available in Pakistan with a lesser cost with the Indian version, but benefit of only 30% reduction is not really promising. Coming to the gene therapy, as my honorable teachers and my honorable professors from London and Cyprus have discussed, it's a promising therapy in future, but it will be available like in Pakistan, bone marrow transplant. We have 20 years experience of bone marrow transplant in Pakistan, in Pindi, Karachi, and different places, but less than 1% of the patient can access bone marrow transplant in developing world scenario. Even if gene therapy comes, it will be less than 0.1% of the patient, but in next 10 years, maybe it will be more cost effective and we may have. So gene,
Thank you very much.
Yeah, last thing, the gene editing with CRISPR gene. Look at the concept which we are working for last 20 years, and we have published more than 20 papers from Pakistan and many papers from India and Iran. CRISPR gene is increasing hemoglobin F formation. They are doing increasing hemoglobin F formation.
Thank you very much, Dr. Saqib.
Sure.
We have other panelists on board.
Sure.
We will come to you again
Sure.
if we have time.
Sure.
Now I would like to ask question to Dr. Samina Amanat. Excess iron absorption is another factor for iron overload in thalassemia, and it is also a bottleneck in the management of these patients. Could you please comment on the new emerging treatment modalities that can balance that iron overload, and then would these agents can replace iron chelating agents which are currently in use? Over to Dr. Samina.
Hello, आवाज आ रही? Hello.
Yes, we can hear.
Okay, thank you very much for asking this question. Well, new modalities which are available for iron chelation, I mean the only ferroptin inhibitor which is available so far, and other drugs like minihepsidine and Tempest antagonist and BMP6 agonist, they are in pipeline. But still, how do they act? Basically, ferroptin inhibitor, which is being used or available right now, it acts, it inhibits ferroptin protein, which is the main transmembrane transport protein, which transport the iron from the enterocyte into the portal plasma. So if you inhibit that, we can, of course, stop the decreased absorption of iron from the gut. But still, the secondary iron overload from the blood transfusion is still there. So I can say this. Now that another is minihepsidin, which is a synthetic hepcidin, and it is in pipeline. But when it is, because we know that when hepcidin is increased, it decrease absorption of iron, and when it is decreased. So the problem is, even if we have these new drugs, the secondary overload by the blood transfusion is still there. So what we can say that synergistically, if we use these medicine along with the chelation, maybe the dose of chelation is reduced, and the new drugs which are inducing HbF, they will decrease the ineffective erythropoiesis. So the iron overload will reduce. So synergistically, we will use these drugs.
Thank you, Dr. Samina. Now I would like to ask a question from Dr. Shahtaj. Could you please comment Pakistan scenario? We have listened to the speakers, and many emerging drugs are in pipeline, and few drugs have FDA approval. Could you please state the Pakistan scenario? Where are we in terms of thalassemia care? And could you also share your own experience of KPK?
Thank you very much for having me. 10 years back, I told Michael that I am in the first few lines of your slides. And today again, his first few slides was blood transfusion, iron chelation, monitoring organ damage, plus minus, and early detection of organ damage. Again, it is plus minus here. Very few go for BMTs. Hydroxyurea is being tried, and with a lower success rate, as probably our genetic mutation doesn't match that. There are 2-3 consultants who are using thalidomide, but that's a debate because there have been no clinical trials on it. And as we know, every patient has an HB below 5 or 6, and they're kept in that way. So there's a big discrepancy over that as well. We don't have MRI in KP, so we have to send it abroad. As far as prenatal diagnosis is concerned, we have to do the prenatal CVS here and send it to Pindi, mostly to General Suhaib. So that is the basic scenario here. Prevention pay, I just want to share a few words on that just 3-4 days back, a team was sent. I was a part of just monitoring the team. The team was sent to South Waziristan, Wana, and they had the army people with them as well to just see the burden of thalassemia, because we were receiving many thalassemic patients from there. We wanted to have a family study and try to counsel them. We were prepared to receive the samples last night, and we were prepared for around about 500 samples, because in case General Suhaib also knows the scenario, I think, because he was also called for that. And to my surprise, last night at 12, I received a call that hum aa rahe hain aur hamare paas 26 samples hain. So taboos, they don't want to be a part of the diagnosis. They don't want to, we are failing to counsel as a government. Policies nahi hai hamare paas koi registries nahi hai. We don't know what is the burden, at least in KP and in Pakistan as a whole. Punjab is the only province where everything is being done. In KP is far behind that. So that is the scenario. And of course, Reblozyls, that is beyond any treatment. BMT is the only solution that we see here, which is not available here. So hamare patients are either sent to Pindi or to Karachi. That is the state of affair here.
Thank you very much, Dr. Shahtaj.
Can I make a comment here?
Yeah, sure.
Dr. Shahtaj, you're not alone. I'm sailing right behind. Wherever you need my help, I'm here to help. We can extend prenatal diagnosis services to the entire KPK if you just follow a few instructions. Thank you.
You're always there, sir. You're always there. I know that. You're always there. We send it to you, of course. We always have your help.
I'll just make a comment here. Although I live many thousand miles away from Pakistan, but my heart lives there. And I have been just advising, to be honest, mainly on the prevention of thalassemia front. And we had a very successful session with Dr. Shahtaj. Unfortunately, she's very right that the political will is far less. And in today's session, we heard that there is no quick fix for thalassemia. So answer is really prevention. And yes, Punjab Thalassemia Society has done a very good job. There's no question about it. It needs to be replicated in other provinces. In Sindh, I can update you a little bit. In Badin, Harun has done really personal efforts to replicate what Suhaib published, and did a really extended screening in affected families. But this is really very little and is a drop in the ocean. And all the governments from Pakistan, including Sindh, KPK, Balochistan, has to come forward and put money into it. And if we don't do that, we will keep producing these affected children, which will not see their 25th birthday, unfortunately.
Thank you, Dr. Kakepoto. I have a question for Professor Rees. Would you like to comment on gene therapy versus transplant, cost effectiveness and quality of life in terms of quality of life of patient, especially in Pakistan scenario?
Oh, thank you for asking me to speak. I think in general, obviously, there's very little information about gene therapy worldwide. You know, a handful, fewer than 100 people have had gene therapy for either sickle cell or thalassemia, and compared to stem cell transplantation, where tens of thousands of people worldwide have had it. So far, gene therapy is very expensive, and to cut a long story short, doesn't work very well. Really, it works if you're in fairly mild thalassemia, then it converts some people to. So as for hydroxyurea and all drugs, the more less severely affected, the better it works. So the severe cases at the moment, gene addition, done by Bluebird Bio, largely hasn't worked very well, particularly in thalassemia. It works in the less severe cases. Bluebird Bio, who are doing all the companies, have withdrawn all their activities from everywhere except the States, though they've stopped doing research and trials in Europe because I think it wasn't licensed by Europe because it was too expensive, and it uses older technology. So as someone mentioned, gene editing is emerging as a potentially better way of doing that, but that still is maybe 10 people in the world have had that. And I think it has the potential to be the curative treatment, but it's still a very long way from that in terms of the techniques available and particularly the cost. As I think I said in the talk, then the future is gene editing to sort of possibly to correct the thalassemia directly, or maybe to boost the hemoglobin F, and the mode of delivery will be in vivo, so to get away from the the danger and expense of stem cell transplantations. So, and it's not, and commercial companies in Boston particularly already developing this, but probably the future is that it will be effectively like a vaccine, that you have an injection with the virus that directly targets your hematopoietic cells, corrects the variant causing thalassemia or boosts the hemoglobin F, and leads to a sort of significant improvement in symptoms. But at the moment, I don't think there's any comparison really. Stem cell transplantation is an established treatment that works for where it's available. Certainly if you have a sibling donor, works well for patients. Gene therapy is an experimental thing, which is hugely expensive, that at the moment doesn't work that well, but almost certainly is the future. And that's true everywhere. That's true in fact, I'm sure it's very true in Pakistan, but it's true in the whole world, including the States.
Thank you very much, Professor. Now I would like Professor Samina to comment, say a few words. Then I would request Dr. Kakepoto to conclude the session. I would like to ask Professor Samina, please comment, would these innovative treatment modalities make paradigm shift in resource poor country at present? And what is the way forward for Pakistan?
Thank you. I wish to thank the organizers for the invitation. And I want to congratulate them for a wonderful program that they have, organized. Well, and the speakers today, they were very learned, very experienced, and they shared excellent, valuable information. Now, for your question, I think it has been answered by the other panelists also. But to summarize, I think that talking of the innovative treatment modalities that you asked for the hemoglobin disorders, gene addition therapy is so expensive, as you know, that it has been withdrawn even from the European countries. So, what to talk about our own? And as just Professor David Rees said, it's the gene addition that is a hope for the future. And we can just hope that it will be, enough. I mean, the expenses will be decreased enough that Pakistani population will be able to afford. But anyways, talking about the treatment modalities, the other ones, luspatercept, again, is extremely expensive, as also already discussed, more than 10,000 euros weekly, not practical for us. The other drugs like mitapivat and Imara and vemiferbot, they are still undergoing trials. So in my opinion, the new treatment modalities available right now, they will further increase the inequality of treatment between the rich and poor countries, and unless they are made more affordable. And asking about the way forward for Pakistan, I think the most important thing for us, as already discussed by General Suhaib, is a very robust thalassemia prevention program. That is what we need. We were all, talking about treatments, further modalities, and just look at it. The number of thalassemia patients are increasing. So the first and foremost way forward is to have a robust thalassemia prevention. And of course, for that, we need screening and prenatal diagnosis, proper government policies for that. And of course, then the second thing is to improve the quality of the existing healthcare for thalassemia patients, and for which we have to add registry and careful follow-up of the patients. Thank you so much.
Thank you, Professor Samina Naeem. Now I would request chair of the session to conclude the session, because we are lagging behind the time, and our general body meeting is like delayed. So, sir, kindly please quickly conclude the session.
Okay, thank you. Somebody was asking question, but I think that can be asked in a later session or privately. I really congratulate the organizers. They're excellently organized. It's perfectly going in time, and the talks were excellent. Professor Rees really covered what is available for sickle cell and what is in the pipeline. And similarly, Professor Angastiniotis from Cyprus, really he is a chief of Thalassemia Federation, and they have been really guiding us and all the third countries in terms of prevention programs. And of course, Professor Suhaib, his excellent talk on diagnostics. I mean, these are basic for our kind of countries, really. And this is really a very, very good lesson for the newcomers. And similarly, Professor Nisar did a very good job for those who are in training. So overall, excellent session. My concluding remarks will be what we have learned from this session. There's no quick fix, as I said earlier. Everything is experimental or too expensive for our kind of patients. So what we need is, majority of patients are thalassemics. What we need is really a prevention, good, robust prevention program. And somehow our government needs really arm twisting, that they need to spend money on such programs. And we already had a very successful program in Punjab. It just needs replicating in other provinces. That's all I have to say. Thank you.
Thank you very much, Professor Dr. Kakepoto. This is the end of red cell session, current and future strategies. Now we have general body meeting. Over to Dr. Salim in 5 minutes. We have general body meeting in 5 minutes. Links are already shared. Kindly stay connected. Thank you very much.